You can't just look at FSH. You look at FSH and estradiol. The other thing is that as your estradiol goes up, your FSH is going to go down. So sometimes if you have other reasons that you have elevated estradiol, it can falsely lower the FSH and make you look more fertile.
Well, this is a super fun day for me to get to talk to my colleague, local hero.
Oh, God.
Menopause expert, author of Menopause Bootcamp, Dr. Suzanne Gilberg-Lenz. Hi, Suzanne. Thank you so much. I know you're super duper busy.
For you, Danica, I'll do almost anything.
Oh my gosh, that's really kind of you to say. But when you're talking to me, it's for a particular community, right? It's women who are very anxious about baby making. And with good reason, I guess, but there are things that we can do using our mind, using our smarts, using our community and our doctors that have the language down or that want to talk about empowered patients and what they can do, right?
100%. Yeah.
So you have delivered approximately how many babies?
I mean, I don't know. I never really counted, but thousands.
Yeah,
thousands.
exactly.
I've been in practice for 26 years. I did births for 22 of those years in a pretty high volume practice. So I think probably conservatively 2,000, something like that. It's crazy. Mm-hmm. It's crazy.
You almost delivered my boy, Jack.
Yes. That's absolutely true.
Yeah. Then Dr. Goldberg came back from vacation.
That's right.
Yeah. So we go back quite a ways.
Oh, yeah. We go back a ways. Yeah.
But what we want to talk about today is, women who are trying to get pregnant, the last thing that they want to hear is they have a low egg reserve, because when they hear that or an elevated FSH, then they immediately rush to, does that mean I'm going into menopause?
Right. Yeah. And so here's one of the things that I've been really thinking about more recently, I'd say in the last year or two. I mean, I did, as you mentioned, I attended birth for a long time, and was very, very involved in the birth community and in obstetrics. And then over time got more interested in menopause. I think some of it was like my patients were aging, I was aging, and it was an area that I realized really we didn't have a lot of training in. So the crossover between perimenopause and pregnancy is really, really interesting. And I think especially in a community like ours, where a lot of moms or a lot of women are heading into childbearing on average older than in the past, older than maybe in other communities, we deal with it a lot. We deal with a lot of concerns about fertility. We deal with a lot of actual fertility issues, and we deal a lot with this kind of testing and like, what do you do with that test? So first of all, the AMH, the anti-Mullerian hormone, was developed in order to assess who is going to be a good responder to in vitro fertilization. That's not the same thing as being a fertility predictor. It's leaked into sort of common use in that way. And it's okay to do that kind of testing, but you have to contextualize it. So when you talk about empowering your listeners and your patients, you understanding what that test actually means and how we're using it is really important. Hopefully the doctor, the clinician you're working with will explain these things to you, but often that doesn't happen. It falls through the cracks. People don't have time. People make assumptions. People come in and ask us to do this test, and we're just like, oh my God, I have 7 minutes to see you, and we're doing your PAP and all your screening, and now you want to do this. I'm just going to do the test and we'll deal with it later kind of thing. I mean, that definitely happens because your doctors are under the gun. So I just don't want people to do testing and not understand what they're doing. It's not a quote fertility test. That's really not what it is. So that's the first thing I want to say. So over responding to that, you got to be careful. The anti-Mullerian hormone is going to tell you about roughly what we call ovarian reserve. And it's going to tell you there's no such thing as an egg count. That's not a thing, but it is a reflection of how many eggs are left. What you guys may know or not know is that we have the maximum number of eggs in our ovaries when we are 20 weeks gestation inside of our moms. Mm-hmm. We're losing eggs from there on. And we have millions and millions. At birth, we're going to have our maximum, hundreds of thousands. And then over time, we're going to lose them from ovulation and just, atresia, like cell loss. You still have a lot of eggs. But the AMH is merely a reflection of the number of eggs. It's not even really a reflection of the quality of those eggs. So is it true that your fertility declines as you get older? Yeah, it is. That's just a fact. We know this. But that AMH number, we got to be careful what it actually means, right? Doesn't mean you aren't going to get pregnant. It does mean you have less eggs. Mm-hmm. If you have less eggs, you have less opportunity to get pregnant.
And it also, just to further on your distinction, it doesn't mean that you have that high AMH or that low AMH and then you're going to go into menopause right away.
Not right away, but AMH is a fairly okay, and I'm going to say okay for a reason, predictor of menopause. But we're talking, those numbers are like 3 to 6 years. It's not, so I focus a lot on midlife at this point. I see patients of all ages, but I'd say the majority of my patients are midlife and beyond. And so some of those people are people who do want to get pregnant, by the way. I don't test AMH for fertility, for menopause. Like, why? First of all, menopause is a physiologic event. It's developmental. It's not diagnosed really diagnosed. First of all, it's not diagnosed because it's not a pathology. And your labs are not really where it's at. It's not that labs couldn't support your journey, but that's not how we treat. It's treated clinically. It's not a disease. Now, here's where it gets complicated and what I was sort of alluding to. As our patients are aging and we're seeing people entering into perimenopause, being more aware of their perimenopausal journey and also trying to deal with their fertility at the same time, it is different. It's a different situation. And the other thing, I don't want to jump far ahead, but I really think a lot about people coming postpartum, being in perimenopause and not realizing that those two things are coinciding and how they impact each other, because they really heavily impact each other. I think for a long time we were like, you're 42, you just had a baby, of course you're tired. I mean, yes, but also you're perimenopausal. So
that's exactly
there's other things.
That's exactly why I wanted to talk to you about this, because who better than a busy gynecologist who's now really focusing on ovarian age and ovarian function than to speak to somebody who delivered those babies and then helped the women in postpartum.
Yes. I think there are things that I didn't really think about until recently. And now in retrospect, I'm like, oh gosh, that was, that's why your libido never came back or whatever. I'm just throwing something out there. That's why you had frozen shoulder when your baby was 4 months old. And there's just stuff that we didn't, you don't know what you don't know. And I think that our clients and our patients don't always know that. And so it's important for them to understand that, so that they understand what their journey might entail. They understand what the resources are. They understand how to advocate for themselves and what questions to ask, so that they're seeking what they actually need.
To get what they need, to get some help, and to improve quality of life.
Yes.
In that postpartum window, but also for them to understand, even if we go on the low end, you said that low AMH can suggest 3 to 6 years left of egg reserve.
Well, it depends on how low it is, right?
Exactly. If it's 0.001,
then it's probably a lot closer. But I also like just to level set. The reality is, look, whether or not we like it, fertility declines over time. Now, every person, don't forget, there's also a bell-shaped curve. So these curves, because the fertility curves and looking at, 35 all that kind of stuff, those are based on large population data. And also they can be very culturally specific and nutritionally specific and genetically specific and things like that. But if we got to use the information we have. So we know fertility declines, it's something like, I think 13 per thousand is the live birth rate at 40. And it's like 76 at 30. Okay, I'm throwing that out. It's probably not exactly right. But I mean, it goes down. It just goes down. But that doesn't mean your AMH isn't necessarily correlated with those numbers. Is it going to be harder between 40 and 45 to get pregnant than 30 and 35? It is. It doesn't mean you're not going to get pregnant. But again, I wouldn't over focus on the AMH. Say, from the clinician's perspective, when I have somebody who's concerned about their fertility and is willing to intervene, the AMH can be helpful, because if you come in at any age and your AMH looks favorable, I think that gives you room to be more liberal in your exploring, right? Or at least understand, like, what is your priority here? Like, how much do you want to have conception on your own, and what are you willing to do that? What are the risks you're willing to take? What are the benefits of trying on your own? How are you going to feel about that? Because every person who walks in does not have the same priorities, context, beliefs, desires, money, all of it. That's just real. If someone comes in at 39 and their AMH is really low and they're like, I want to have 3 kids, I am going to probably send them to the fertility doctor, because I want them to have all the information available. It's not like you have to do XYZ. You need to informed consent means giving information. If I don't give you the information, it is not informed consent. So I often, when I was doing, even now, I don't do obstetrics anymore, but if I have someone who's in sort of that, 38 to 44, age group, roughly speaking, I have that conversation and I tell them, look, having a consultation with a fertility doctor is informational. It's not, you have to do something. It's, I want you to have the information so you understand what we know, what we don't know, and then you get to make the decision about what you want to do. Because the worst thing to me would be, you don't do anything and now you're having a harder time getting pregnant, and you would have been willing to do something like go to acupuncture. You know what I mean?
Mm-hmm. Exactly. I do. This is where, when I first presented this conversation with you, I said, I want to talk to the women about ways that they can love their ovaries. Like self-care comes in as being age 31 and told by various doctors that I was going into early menopause. I went to the acupuncturist and he said, if your body is going in that direction, it will go there even faster if you keep stressing out about it. So the opposite was true of, if I could calm down, maybe I could slow it down.
Yeah. Well, and then there's also nutritional support. We know that things like CoQ10 have an impact. There's a lot of interesting longevity stuff out there, some of which I think is really outlier stuff and I'm not a fan of. But I think here's the thing, and this is where you and I always have bonded. So one of the things that we didn't talk about is that I'm trained in integrative medicine and holistic medicine. I'm trained in Ayurveda, specifically in Indian medicine. I practice conventional medicine. It is informed by indigenous holistic medicine and traditional medicine. And I think, and it's ironic to those of us who have been practicing this for a long time. Now it's like, lifestyle medicine. It's like, well, the original lifestyle medicines were indigenous medicines, right? I mean, it's not just like the prescription, the conventional medical intervention, which are powerful tools that are magical and amazing, and thank God for them. But like you said, your sleep, your stress, your thoughts, how you're eating, when you're eating, what kind of exercise you're doing, who you're surrounding yourself with, what you are consuming media-wise, like all of these things have an impact. Circadian rhythms, these are powerful tools. Your nutrition, your gut. In Ayurveda, I was trained, when you assessed a patient, no matter what presenting issue they came to you with, everybody got a precision-made, individualized herbal formula for their gut and for their mind, no matter what the quote problem was. Because according to Ayurveda, if you don't address digestion and thoughts, you're not going to support health or fix anything. Now we know the microbiome is everything, right? Now we know the second brain is everything. So, Western medicine is catching up with a 6,000-year-old tradition. That's fine. I'm happy for them. But it's not like we didn't already know that. I mean, you literally are what you eat.
Right. Well, Suzanne, I have my online program, Seed Fertility, and it's broken into 2 modules, fertile thoughts and fertile foods. I put that together online 2013, and it's still conceptually hard for people to get their head around because of all the manipulation about all the different diets and the different things. It's become so confusing, but it really is that simple. The way that we think and feel decides how we choose what we eat, and what we eat kind of informs how good we're going to feel and how optimistic we are about baby making and living in general. And the more that we understand that food is medicine.
Yeah.
We can really understand that food is inflammatory and it's at the root. Eating sugar equals diabetes and all of that. But the opposite is true. You can use food to slow down your ovarian aging. I've proven it a few thousand times myself. So yes, that is where we intersect, and having that as a good solid base is very empowering. And I think we've both leaned into it for different personal reasons.
Yeah,
right?
Exactly. We've had our own personal experiences, our own personal medical experiences that have helped us understand that even more deeply. And I think working for many, many, many decades, actually, at this point, with so many people and just watching and observing not only our interventions, but just how they, like, what their experience is. It's very interesting to me. I mean, like, for instance, I just got off a telemed with a patient who is postmenopausal. And she's really had a very hard time with her moods. And I think she really wanted this to be all hormonal, just to be honest. And some of it was hormonal. She really needed hormone replacement. She really needed the support. It was very hard for her to bend her mind around that because she came from more of the integrative and, like, she's always done acupuncture and herbs, and it just was not enough. She was really suffering. It took her a while to get there and just accept, like, well, let me try it. I said to her, like, look, if you don't like it, you can stop. It's not like an amputation. Like, you don't like it, it's not working, cool. But I feel like this is going to help you, right? So she did that. Oh my gosh, it really helped a lot, but it didn't fix everything. And we just did a follow-up, and I, use the tools that are in your toolkit. So part of my practice now, I'm in a membership annual concierge precision, like, very deep dive practice. It's amazing. And we did a full panel on her. And it was really important for us to be able to look at what's her cardiometabolic health and what's her future, right? Because her now is going to predict her future. It's going to set her up for her health or frailty. But her hormone, her estrogen level was great. She's on, and I don't always check this, but with her, it was like, well, you're having all these symptoms. So let's see, is it that you're not absorbing the estrogen I'm giving you and you really need more? Or is this mood? And guess what? Her estrogen levels are great. She's absorbing the estrogen. It's not that. And we were able to have that conversation because we have the experience, we have the trust. I know her. She's doing what she's doing. And she could see that and digest that information and say, okay, so the best way forward for me is to continue what I'm doing. And now the next thing we're going to do with her is we're looking more at herbs and supplements. And then she knows if she needs antidepressants, because that's what she needs, she feels more open to that potential solution because she's had a thorough investigation and a more integrated approach, including her sleep and her stress and all of this stuff. And having that capacity to be able to look at all of these different aspects, because we are complex human beings, makes all the difference in the healing journey. I'm telling you this story, which may seem tangential, because it highlights the importance of data, modern science, holistic and traditional medicine, and the most important aspect of healing, relationship, connection. She trusts me. She trusts my expertise. I trust her. She is the expert of her body. She can report back to me, I did this and this is what happened. That didn't work. I thought, you know what? Maybe you need more progesterone, maybe some more calming. She couldn't tolerate it. She was groggy in the morning. Okay, that doesn't work. Cool. Ashwagandha and rhodiola it is. I mean, that's what we're going to do. And if she needs Lexapro, she'll do it.
Right.
Honestly.
Right. Well, that segue into the connection between the provider and the patient applies whether you're dealing with adolescence, puberty, pregnancy, but particularly trying to get pregnant. It's an anxious lot, isn't it? And I think that's partially why the Baby Makers podcast exists, because I wanted people to see what is possible when the patients get to talk to physicians and holistic providers that can appreciate the different dimensions of women's health.
Yeah. Well, it allows the person to settle into their own being. I think actually I think there's data on this too, but when there's safety and connection, actually there is data. I just did a reel on this on Instagram. when somebody feels connected to their practitioner, their health outcomes are measurably improved in the year following those visits.
Mhm.
But that makes sense. That's common sense. If you feel safe, you can relax into whatever your situation is. You're going to be more capable, I think, of connecting with your own body. And you're not constantly like hyper vigilant searching. You're able, which we know that kind of stress is not going to improve fertility. And if nothing else, it's not going to improve your quality of life on that day. And that day is the only day you have promised.
Right. Well, it lowers cortisol.
Yes.
It stimulates all those neurotransmitters like serotonin and oxytocin. And further, to your point, when women or two people connect and they get on that high vibration and they feel safe, then they also emit a different frequency.
Mm-hmm.
And then you've got that extra person who's excited for you at the
Mm-hmm.
possibility of defying the odds or of becoming pregnant at 44 with your own
Mm-hmm.
egg and that kind of thing. So there's this frequency that's emulating from now both people, whereas
Yeah.
before we had a patient that was like downtrodden and negative and spending more of that.
Well, the
frequency
language
out.
is really important. I think the language that we use is so important. How, just like I think people know self-talk is like something that's, people talk about, right? So how we talk to ourselves is very important, but that means that how we are talked to or what we absorb and listen to. So when we are pathologized and we are the patient, we have to be really careful with that. There are times and places where that is where it has to happen. I'm so careful, Danica, at this point in my career, especially with the amount of burnout that my colleagues are experiencing and the trauma that the medical system perpetrates, not just against the patients, quote unquote, but the practitioners. Like, it's bad. So I want to be really careful that I'm not like pointing the finger or accusing my colleagues, but I think just from the human perspective, remembering that we are a human first and always, and not, like you said, something really powerful, and not about being a patient, about being a person who's experiencing something, a person who is hoping to get pregnant, a person who is wanting to manifest their family. That's a power position. That's not a victim position. That's a power position. And so you can engage with your own agency and you're
Yes.
making better decisions.
Right. Well, and the opposite is true, where the provider is just trying to help.
Yeah.
And there's so much responsibility
Oh,
and
yeah.
pressure and expectation
Yeah.
put on us as
Yeah.
the caregivers in these situations at
Yeah.
each level of care.
Yep.
To help get a baby here safely or to help make genetically normal embryos.
Yeah, reestablishing that human connection from bidirectionally. And I think you and I we've been, I think, blessed in our careers to have those kinds of relationships. But it starts from within, projecting that and like knowing that about yourself, and also being able to hold on to that about yourself as the person who's trying to navigate this system and make things happen for yourself. It's really hard. We have to acknowledge that can be very hard for people, and when they start losing that sense of who they are, that's just it's never a good thing.
Mm-hmm. Well, I think we didn't land here by luck. We are strong women and we listen to our intuition. And the more that we think like that and talk like that, it gives other women around us the idea to do it or the permission to do it themselves. And I think that is, if you remember my colleague Anna, who worked here in the early 2000s, we were all about that. And that was what this whole idea of well women acupuncture was about, was like, well, what do you really believe? And we didn't get there because that sounded cool. We got there because I was 31 and was told I was about to go into menopause.
Yeah.
And so it was very important for me to pause everything and think that through, because really what we believe as the person going through whatever it is going to be like the outcome that we see.
Yeah.
So I would imagine that in your time, I'm speaking mostly on obstetrics, but you have that whole gamut, and we're covering as much and as fast as we can. But with regard to women who believe that childbirthing is going to be hard, they will a lot of the times create that outcome. And so I tell my patients,
that's really intense.
I tell my patients, you're going to get what you need. Do you need like to be proven wrong? Do you need a lesson, or do you need, to get it easily and effortlessly so that you can go on and encourage other people to think differently?
Yeah, that's so interesting. I will say that my observation over the decades that I did attend birth, it wasn't like, I mean, like, let's be clear, neither of us are like trying to spiritually bypass or be like toxically positive, like, oh, you're going to get the outcome. It's not like, oh, think positive and everything's going to be perfect. No, 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 no.
Thanks for saying that.
That's not how that works.
Right.
Like, whatever's going to happen is going to happen. And some of it's really not under any of our control. But I will say that people who get locked down have a much harder experience, whatever that experience is, because anxiety makes everything harder. And sometimes you cannot help being anxious, which is why having a team around you, having people that you trust is really important. Knowing who you are, knowing my go-to is anxiety. Okay, so then I need to have extra support at the birth, whether it's a doula or it's my sister or my best friend or my partner, whatever it is, extra people. And also surrendering into it and saying, like, I trust my team. They're going to do the best they can for me. And whatever's going to happen is going to happen, but I'm safe and I trust that I've chosen wisely. Now, this is complicated, obviously, because we have healthcare systems that don't always honor who we are. We have maternal mortality rates that have massive disparities just based on race, not on socioeconomic, but race. These are realities. But again, even people who know that they may be subjected to something different, cushioning yourself and coming into the scenario with as much safety as possible really does make a difference. And there is a lot of data on that too. People who come in with birth support, whether it's a doula or not, and not everyone can afford that, they do better. They have better outcomes. They just, that is documented. Even if it doesn't go the way you wanted it to go and it wasn't the water birth and all that, maybe it ends up in a C-section, but people can have a positive C-section if they're supported and feel grounded and can, again, surrender to the experience and move through the experience. Like you said, it's the experience that maybe you needed for some reason, but not, it's not something magic. And also, like, your bodily experience is not like a reward or a punishment. It's really important. Like, as a cancer survivor, I remember when I was diagnosed with cancer in my 40s, I was floored. I was doing yoga and meditation. I studied Ayurveda and I ate organic and made my own food. I mean, I made my kids, I don't know how I did it, but I made like most of my kids baby foods and breastfed both of them for 5 million years and all of it. And then I got freaking breast cancer. And I had to really assess who was I? What is my identity? Right? Because I knew it was like, I didn't do something wrong to have that happen. And I didn't do something right to survive it. It's not quite that, but how I navigated the experience was everything. Right.
And how you use it to help your patients now was really necessary.
Yeah. It made me a better doctor. It made me it really helped me hone in on my, being really, really okay with my authentic self and my beliefs. I really doubled down on that. I continued to practice conventional medicine, but I think I was like, yeah, I'm here for it. So this is who I am, bitches. This is how I do it.
Sisters, let's say.
Yeah, sorry.
Would you say that, well, first, before I go there, thank you for sharing that, because it speaks to the fact that we're not broken. And it does say that there are opportunities in these hard things that happen. And so, you could have been like, I got breast cancer and I am so done with women's healthcare. Bye, everyone. See you later.
Yeah.
Right.
Yeah.
But instead you used the Ayurveda and more holistic, and you leaned into that, and then you were authentic with yourself and your patients and said, hey, listen, I want to make time to talk to you about holistic care. So would you say that the same is true with regard to fertility, as this, like, getting a support system and the same kinds of things where we're talking about these outcomes?
Yeah.
That when we're looking at the whole of what's going to happen, to help our patients surrender to not knowing their outcome, and to be a part of that conversation with them, can calm cortisol, can help them as well to surrender faster, which might improve their outcomes.
I think look, as a medical doctor, I'm always like hesitant. I want to say, like, there's my opinion, there's my observation, and then there's the data. And I can't tell you that I did a deep dive on the data, but my observation has been that, much like you're building resilience within yourself, and that means reaching into your community and your resources to bolster your capacity to traverse any experience, whether it's the birth experience, the parenting experience, the medical crisis experience, the career experience, the world experience. It applies the same to fertility, and fertility feels and is very high stakes for people. And I think especially as women, there's all this other built-in stuff that people don't always think about, because there is our personal desire to have a family, right? And then there's a lot of pressure, whether or not we are connecting with it or think about it or it resonates, that as women, are we a whole woman if we don't do this? And I think that has to be said. I'm not saying people are out there having babies only because of that kind of cultural imperative and pressure, which we have internalized. But we have to be careful, because that exists, that is out there. And I think that plays a role too. And I think saying it out loud is important, because it can help maybe release a little bit of that pressure. I mean, the pressure still is there, but knowing, like, who you are and what is influencing your decision making is only going to enhance your capacity to, again, access resources so that you can stay resilient. I mean, resilience is really everything.
Especially nowadays, more than ever. I like to tell the patients that the work that they're doing on themselves is going to improve the future generation, and starting with their own child, because when they learn how to eat differently for fertility, or they learn how to think differently about their health care, well, that part of their brain and that is in them, that new way of being in the world, is something that they're going to hand over to their children.
Absolutely.
So it's not a punishment. When fertility makes you pause, slow down, look at it differently, change your diet, throw in some acupuncture, learn how to reduce cortisol in your system, have empowering conversations.
Center yourself.
Right.
Like, if you don't, here's the thing, like, if you don't center your own experience, you're not going to be able to address any challenge that comes your way, or help anybody else, or really be a decent parent. Like, obviously has to be a balance, but this whole, like, martyrdom thing, which maybe is more obvious as a parent, but also kind of can play into the fertility journey too, where people understandably, depending on what's going on with them, let's say they're having challenges or having a hard time, it's taking them longer than they thought, something isn't working, now they're a patient, they're having miscarriages, whatever, like a ton of grief, a ton of loss. So we have to be able to take care of ourselves, get the help we need, process. That all requires that we center ourselves at some point for some part of it, because if we don't, then you're constantly externalizing, you've lost your agency, you have no power on the whole thing. And it really, when everything's outside of you, you're just moving through it. You're literally a victim of all of it, including thinking.
Right. And you're hyperestrogenized.
Yeah.
So as a menopause expert, can you explain, like, having all that estrogen in the system temporarily, it's going to make you more emotional, right?
Yeah. Yeah. It will have an impact for sure.
Mm-hmm. And I think it impairs the ability to think clearly because
I think that's a mixed
emotional
bag.
reasoning.
I think it's a mixed bag. And I think you have to be careful with that because we do experience obviously hormonal fluctuations that are
Every cycle.
expected. And there is a sweet spot, right? So because you do need a certain amount of estrogen. For instance, it's really interesting. During the pregnancy journey and postpartum, there are very obvious changes to the brain under the influence of hormonal regulation. And what we see in brain imaging is that the amygdala, which is the seat of a lot of emotion, is highly influenced and lights up. And that is probably evolutionarily important because it's how you bond. And if you're going to keep now, so I'm talking about centering yourself. When you have a newborn, you got to keep that person alive. Your job is to keep that person alive. So your amygdala is like bond, 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 so that I keep that person alive. Because otherwise, this thing is annoying me. I mean, I'm simplifying it and being a little flip, but it's really interesting that you talk about that because the hormones absolutely have an impact on our brain.
Yeah.
We know this.
Mm-hmm. Mm-hmm.
Frontal lobes are the big change with estrogen and estrogen receptor status in adolescence, right? Executive functioning turns on, and it is influenced in part by estrogen activity, estrogen increasing, and then these very predictable sine waves. Amygdala at pregnancy, and the hippocampus changes at menopause. And the hippocampus is cognition, memory, word finding. This is why people get some of these problems. It's pretty interesting. So we have data on this. This is newer research. It's very interesting.
I think it's fascinating.
Yeah.
Thank God now the men have their 300 little blue pills. We can finally start figuring out what we need.
Yeah. Well, yes, the whole other podcast.
Yeah. We talked a lot about AMH. We're talking about the brain. It's a good time to talk about FSH.
Yeah.
Because as a gynecologist, I'm sure you had patients come in telling you that they had elevated FSH.
Right.
And I also want to talk about when FSH is too low and we've got hypothalamic ovulatory dysfunction.
Right.
So those are more direct indicators of fertility in the sense that they're telling us how hard your ovaries are working to ovulate.
Exactly. So the FSH is the hormone that is made in the brain. Okay. You have the anterior pituitary and the hypothalamus talking to each other. And then they're talking to the ovary and saying like, hey, time to pick an egg. And it's this conversation and it's a negative feedback loop. So the lower your estrogen, the higher FSH is going to be. Okay, this is a really complex story, so we're gonna simplify it as much as we can. But FSH is the follicle stimulating hormone, and it is responsible for allowing the ovary to pick a follicle where an egg will develop and eventually be ovulated from. And that is where your estrogen is really at work. The thing about FSH in a very specific period of time in your cycle is it's quite predictive of how hard it is for your brain and your ovary to talk to each other. And there again is a sweet spot, but it is only that month that it is telling you about. So you got to be careful with that too. It's definitely when we talk about fertility prediction and AMH, FSH really is a much better predictor, except I talk about this all the time. Like I told you, I just saw a patient and I did labs. Almost never is one lab or one factor the thing. It just, you have to look at so many other factors. So FSH could be a screening tool, but it is not everything. And it is very reflective of that cycle in particular. So, it's a much more complex conversation. What is your blood sugar? What's your cardiac health? Like so many other things, it's just, you can't just look at FSH. You look at FSH and estradiol. The other thing is that as your estradiol goes up, your FSH is going to go down. So sometimes if you have other reasons that you have elevated estradiol, the estrogen that we're really talking about in this particular case, it can falsely lower the FSH and make you look more fertile. So this is complicated, and I'm not a fertility doctor. But again, I think, using hormones as a tool, using lab testing as a tool in a larger toolkit is fine, but it is never just one thing. And as you mentioned, FSH can be too low. And it's not just looking at FSH, you have to look at a bunch of other hormones. So again, if you're not having a period at all and there's suppression, why is that? Are you under eating? Are you under stress? Do you have another medical issue? Do you have a thyroid disorder? Do you have prolactin, another brain function that can, really is supposed to be made so that you can lactate, you can make milk, and it suppresses ovulation. There's a lot of other things we have to look at, and we do have to look at the total health. And I think you and I probably over the years have seen a lot of people who are super stressed and or have disordered eating or eating disorders who are not ovulating, their numbers are off, they're not getting pregnant. And it's really a deeper journey for them because it isn't a matter of like, I'm going to go to the fertility doctor and fix this. I mean, many people do that and override it, but there's an underlying health issue that really needs to be addressed. And it's a mental, physical, and spiritual health issue. And I've picked that up a lot over the years. And that's a hard one because people are resistant to hearing that. They're like, I'm doing this. This is my goal. And it's like, well, okay, that's cool. I hear what your goals and I want to support you, but I actually want to support you on your entire health journey. Because if you want to be a healthy pregnant person and a healthy human, we got to actually deal with your foundational issues.
So a lot of times, because I imagine you've seen a ton of patients that are not getting their period, right?
Right.
So whether it's in Chinese medicine, we say like an excess scenario, polycystic ovaries, the classic type where overweight, facial hair, not ovulating, and there's a bunch of secondary follicles. Then there's the anovulatory because she's become too thin, too stressed, not sleeping, not eating enough of the right stuff. So when they're not menstruating, let's just talk about some of the more thin atypical, which is really, we want to find out, is she ovulating or not? And how do you help them from a medical standpoint? Particular type.
For the medical standpoint, I'm really like looking at labs, making sure there's nothing else going on. There's no other underlying health condition that needs to be addressed or corrected. And then I'm not doing all the counseling. That's when I'm sending them to the acupuncturist, the dietitian. Some people I've seen over the years, like really athletic people who are over exercising, runners. I've had a number of runners over the years who like, they're just running too much. And they love their running. Their running is their drug of choice, but like it's suppressing ovulation. You cannot run that much. Honestly, when I've seen people like that, usually, Danica, it is in the context of a disordered eating or eating disorder. Usually, that can be part of it. But you could have, a thyroid disorder or some other medical issue. It's in this community, it is more
here in LA,
former than the latter. Yeah,
the former than the latter.
More like lifestyle.
Too thin, too stressed. Yeah, too upregulated.
Yeah. And a lot of PCOS, we all see a lot of PCOS. I mean, PCOS is very common. It's like 1 in 5. So, and I think it's getting more common. Lots of PCOS. And all the PCOS does not present in PCOS first of all, we are continuing to talk about changing that name because polycystic ovarian syndrome is not really, it's a metabolic disorder. It's a metabolic disorder, and it puts people at risk for cardiometabolic disease as they get older. And they need to know that. But not everybody is the classic. It's a spectrum. So some people have more overexpression of androgens. So they may have something called DHEA, which is a adrenal hormone, which is a precursor to estrogen and testosterone. They may have more insulin resistance, which would be more like pre-diabetes or diabetes-like. And so it's really important to assess all those things because those things actually can be have really amazing impacts with lifestyle.
Oh, yeah. I'll never forget the 40-year-old Latina patient that I worked with who came to my office crying after one appointment with a fertility doctor who did one ultrasound, no blood work, and told her that she had no eggs because she was late on her period. And she had this referral. So she came to me because a friend suggested, and I said, I don't think that you have no eggs left. Let's do some lab work. Let's look at your metabolic function. Lo and behold, turns out she was diabetic. Her cholesterol was high, and I got her onto some supplements to bring the blood sugar under control. And we drastically changed the diet, and I sent her to a different fertility specialist. The first month, there was quiet ovarian activity. The second cycle attempt, she had 2 follicles. They did an IUI. She now is the mother of boy-girl teenage twins.
Oh my gosh, how wonderful.
So it was 100% metabolic in that scenario. So
and she learned about she learned about how to take better care of herself.
Yeah, for her children now too, right? And her whole family, her relationship.
Yeah.
So you, I'm sure you would agree, because we've been doing this for so long. It's just so loaded what I'm about to say, and so obvious at the same time, but our fertility, I don't think, and our metabolism have not been helped by coffee stands on every single corner, whether it's like double, triple shots of espresso and iced tea without sugar, or all these frappy, sugary, frothy, cold, high calorie, high sugary, syrupy.
Yeah, and let's not forget that they're all the microplastics that we are consuming.
Assuming it from,
to bring this up, but like all of these hot beverages. I mean, I've been drinking them for years too. Hot beverages in these lined cups, and oh my God, there's all this stuff coming out about like how much microplastics are in our bodies. I don't know what the fertility literature says. I know that there's some pretty alarming stuff about like people who've had carotid artery clots and had what's called an endarterectomy, where they actually remove the clot because they were at risk for a stroke or they had a stroke. And the people who had more microplastics in those clots had a higher risk of stroke in the following year or something. I mean, again, it's common sense. Like we probably shouldn't have plastics in our, like as part of our bodies. So I feel like this is going to be triggering because there's like, what can you do? But there are things you can do. So there's a lot of things. Look, I'm a coffee person. I love coffee.
Me too.
I have 1 coffee a day. Now, I mean, now that I don't do OB, I don't need to drink as much coffee. But you're right. There's all this stuff. And also just like, I mean, this is like common sense, right? You got to do what you got to do. You got to live in the world. The more processed stuff you're taking into your body, the less healthy your body's going to be. Every index of health declines as processed foods, including all that kind of stuff, increase. That's just the way it is. So again, informed consent. Information, you get to decide what you're gonna do. Look, I travel a lot for work. I cannot eat the way I want to eat all the time. Am I like that crazy person that travels with ground flax? Yes, I am. And a lemon. Yes, I am. That's what I do. I do. It's like really, I'm that person. I have my little collagen sticks. Okay. Like I do what I do what I can to continue to have some kind of structure so that I feel better, because that works for me. And I think we just have to, again, we have to live in the world, but I think we should live by the 80-20 rule.
Yeah.
80% of the time, you're really doing the best you can. 20% of the time, you're doing the best you can. You're always doing the best you can.
Right. Well, let me go a little sci-fi for a sec, because one of the ways that I help my patients to relax and to achieve that 80-20 thing is to really explain humans are evolving. We are evolving to need technology to procreate, and the technology is advancing quickly. And so while I understand and appreciate we want to drink our water from glass as much as possible, there is a future. I think this is just Danica science fiction. Mumbo jumbo, take it with a grain of salt, but there's probably a future version of humans that's made of plastic and metal.
Oh my God.
And so
I think that's called robots.
Right. Well,
and they are coming. They're here.
Yes. And then there's going to be an interface,
Wow.
Humans, I think.
I did not anticipate this conversation going there.
Yeah. Well, I think I don't take it there very frequently, but just saying we do what we can. We do the best that we
That's
can.
exactly.
And
We're here. We're here on the planet. We're doing the best we can. That's
yeah,
it.
right. So the more that we stress out about it, the worse we probably make it, is
Oh,
really what I'm
totally.
trying to say.
Yes. Good advice. Sage advice. I like that.
Yeah, I think, thank you. The final thing that we should talk about is the role of inflammation.
Mm.
Something you know a lot about. If you could put it in the context of fertility, that would be awesome. When we're becoming inflamed through emotions, food, um, it shows up in what ways, would you say, through with
Oh,
respect to fertility?
I mean, it's so global because, okay, so first of all, I think inflammation is a little bit of a buzzword. We do need to have some inflammation in our body. Part of the
Sure.
process of ovulation is going to require inflammation. You're not
Exactly.
going to release that egg from the follicle without inflammation.
Mhm.
So it's really important to understand what the terminology is and that it's about excess inflammation, right? Because inflammation is a normal response. It's also how our immune system works to fight a foreign invader. That's why you get a fever. It's literally surrounding and consuming, a viral particle. So there are good things about it. But what you can imagine, if you were to always be in that inflamed, elevated state, your immune system does not function the same way. So for instance, your immune system is going to burn itself out. It's not going to be able to attend to the things it needs to attend to. Your gut microbiome is going to shift, and your gut is setting up your entire experience. I mean, most of your neurotransmitters, a lot of hormonal processing occurs in the gut. People don't really realize this. I think people think of hormones especially with fertility, as ovaries. And now we talked about brain, but your gut's involved. Your gut is involved in estrogen regulation. Basically, some of the excess estrogen gets processed via the liver into the gut and excreted. So you're going to disrupt all of your body systems, right? Your blood sugar control is going to be different. Your blood sugar has a huge impact on your metabolic rate, on the capacity to ovulate. I mean, I could go on and on. There's the stress hormones in and of themselves. When you're on constant high alert, they have an inflammatory effect. And all of our major chronic illnesses require, at least at one point, inflammation. And so we're talking about cardiovascular disease, diabetes, dementia, osteoporosis, cancer. So we're not only decreasing our health span, and we know women have a longer lifespan, but we live it in poorer health. So you're decreasing your health span, but you're impairing your fertility because you're disrupting this constant conversation that your body is trying to have with itself. We already talked about the fact that it's a miracle, and it's this intricate relationship between the lining of your uterus, your cervical mucus, your ovaries, your fallopian tubes, your gut, your brain. Like, all of these things get to interact. It's so beautiful, and it's amazing that it works at all. And it's also very resilient, let me just say, because people are getting pregnant in a refugee camp. Okay. That's a thing. So people can be under duress and get pregnant. But the more the more we're pressuring our own resilience, the harder it is going to be. So there are very specific ways that our fertility is impacted by these high inflammatory states, like I mentioned, and then generically just our health is impacted. And a person who is in less good health, ovulation is not a survival benefit. So
Yeah.
it's going to be harder to ovulate. Your body reads that stress as, wow, you know, I'm being chased by a saber-toothed tiger. Now is not the time to stop down and release an egg. All hands on deck. My energy needs to go to the flight. So when you're in constant fight, flight, freeze, your body reads it, even though we are evolving to be robots. We just heard today. We evolved really rapidly, and your body reads it as survival mode. And survival mode does not include fertility in that moment.
Mhm. Yeah. Meaning if there are 7 different main body systems, cardiovascular, that's going to be prioritized over the reproductive system.
You got to run. You literally got to run, because if you do want the species to survive, you've got to live another day, find safety where you can relax, and you can then ovulate and conceive. I mean, that's just the way it at a very basic level works. And so when our body even when we're doom scrolling, which we all know is bad for us for a million reasons. You can't sleep, you can't think, it gives you I get a stomach ache thinking about it. When we're doing that all the time, your body is reading it as, you know what? If you're going to stay alive today so that you can ovulate in 2 weeks, you're not ovulating now.
Yeah.
Because being pregnant is not going to keep you alive. Being pregnant is a massive stress test.
Gosh, would you say more about that?
I talk about that all the time because I do so much midlife health. One of the things that I always ask my incoming patients and always talk about with the people that I'm working with is their pregnancy history, if they had a pregnancy history, whether that included miscarriages, live births, what complications they had. If you are pregnant and you have a major medical complication like any hypertensive disorder, placental abruptions, diabetes, mood disorders, that is a predictor of your future health. So again, this is a really powerful tool to understand though, because if you know you had gestational diabetes, then you need to know that you have a 50% increased risk of diabetes later in life. And guess what? You can intervene. You can eat differently. You can exercise differently. You can be assessing differently. You can make sure that you're getting your blood sugar checked and that you're doing everything you can to decrease that risk. A lot of times people don't know that. They don't realize that the stress test of your pregnancy is giving you it's just information, and it's information that we can act on.
Do something with. And that's why it's so important when we're trying to conceive or preparing for conception to handle that stuff.
So important. Yes. Yes.
So absolutely. I think if anything, this conversation really speaks to that part of, ladies, you're not broken. If infertility is up for you, there's something you got to do. Put on a detective hat, talk to your care team, and start figuring out where are the things not optimized, where can you dive in deeper.
Yeah, where are the opportunities to increase your understanding of yourself and thereby increase your health?
Well, is there anything that you would like to leave the listeners with, the audience who's really thinking, what do I need to do? Where do I begin? If there's somebody who wants to get pregnant and they haven't, there's just so much that people can access from listening to podcasts.
Yeah, absolutely. And there's so many resources online. I will say, though, it can get really overwhelming. And so my advice would be to try to limit your exposure in some ways, because it is wild out there. And of course, Danica and I feel that we know we're well trained, and we know that we're resources that are vetted and legitimate. But it can get pretty wild out there. And I think I'd just be really careful about where you're getting your information. And, you probably know professional organizations that can be really beneficial for patients and for human beings, just for getting resources, getting help. I mean, not everybody's going to be in a community where they can access a professional like you, but they might be able to follow you online, do your course, or, maybe there are professional organizations where they can, for us in conventional medicine, I think the telehealth solutions are really, really helping increase access in places where there aren't doctors like me. And then if you're local, I like I said, I don't do birth, but I have patients that are in their 20s. I have lots of patients. I have patients that will get pregnant, leave, and come back to me. So I'm sure you'll share my resources.
Absolutely.
Yeah. Yeah.
But for the listeners, what is your Instagram handle? It's Ask Dr. Suzanne.
My main Instagram handle is Ask Dr. Suzanne, AskDrSuzanne. I think if you go to my website, you can find everything, including my practice. And I have another book that I haven't announced yet, but that will be coming out on plant medicine, on botanical medicine. So that's exciting. So that's the Dr. Suzanne, THEDRSUZANNE.com. Yeah.
Love it. Love it. Well, it's so important, the work that you're doing, and the fact that you are willing to come on and talk about fertility when you are the menopause expert that we all need.
Yeah.
It means a lot to me and to
it's
this
my
community.
Pleasure. Thanks for having me.
Of course. Thank you so much.
Thank
Suzanne, we will keep the conversation going.
Yeah, for sure.